Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Everyone, welcome back. We have another exciting episode today. Dr. Sand is going to lead us through a discussion on antidepressants and the gut. Take it away.
I am not very hopeful that this is going to be a positive discussion.
Why?
I am pretty hopeful that we're going to end up basically coming away with lots of things like
No.
antidepressants. Oh, no?
No, you just need to know what you're using and why.
Oh, okay. That's better than I
And
thought.
let's face it, lots of people are on antidepressants. So we really want to be well versed on what causes what, why, what to tell our patients, how to know what to expect, those sorts of things. So today we're just going to be covering 3 classes. There are tons of others. I mean, I think we can all agree they affect the gut to some variety, but some of the most basic ones given, especially for just gut stuff, tricyclic antidepressants.
Definitely use those for gut stuff.
For
Yeah.
gut
IBS,
stuff.
Yeah.
SSRIs, and then a little bit we'll touch on SNRIs. But I want to kind of go through a lot of them, how we use them, why we use them, and what they're doing to our gut.
I feel like tricyclics is everybody should know about tricyclics
Yep.
and IBS. The data is pretty adamantly
So no
good.
standby.
Yeah.
For some people.
Okay. ...
In general, our studies on this, on how psych drugs affect the gut, are short in they're not. We need larger efficacy studies on them. We need longer duration and bigger sample sizes. They don't tend to track these people very long in the studies we have, so longer term data we're lacking.
Oh, really?
Yeah.
Huh.
And it takes, depending on the drug, weeks to take effect, right?
Yeah.
So it's a short window. We have data, but all of us know they affect it. So basically we're looking at gut-brain axis support. Have you heard of the gut-brain axis?
I don't believe it exists.
Anyone?
There's the gut and the brain. They're very different.
Yeah, they're
obviously.
2 feet from each other.
Yeah.
They can't possibly, So a lot of the mechanisms of action aren't totally understood on a lot of these drugs. And I'm not just talking about what we think they're doing in the brain and with mood wise. We know the receptors they're working on, but how that actually translates to mood stuff and effects in the gut, we're still figuring a lot of it out.
Mm-hmm.
And they're made to be mood stuff, but obviously they do affect other systems. So let's start with the tricyclics.
Okay.
Can anyone name?
I think I can.
Okay.
Amitriptyline, nortriptyline.
Those are the 2 main ones.
Those are the 2 main ones?
Yeah.
Okay, those are the 2 ones I use in clinical practice.
Yeah,
so
I think there are 4 we've got. But antidepressants are known to work at the level of the brain and the spinal cord to block pain messages. So think about what our GI patients we'd be giving this in.
Can I guess? A GI patient with pain.
All our GI patients. Okay, yeah. So the visceral hypersensitivity is sort of what we're getting at with these folks, but between the GI tract and the brain and the spinal cord and the brain, this is where they're working. So this is true of all of the classes we're covering here. We are not going to be using these in folks who have chronic idiopathic constipation,
Right.
things like that, where they don't really have the pain component. So
We're not even going to use it if they just have diarrhea or bloating.
Mhm.
They need to have the pain.
exactly.
This is a pain drug.
Yep. So what we know is happening with these drugs, with the tricyclics, is they're acting on norepinephrine and dopaminergic receptors. They also have anticholinergic effects.
Ooh, we learned about that.
Yeah.
That one was a little bit of a brain twister way back when.
Acetylcholine is
Yeah. Anticholinergic.
a prokinetic.
Acetylcholine is a prokinetic.
Yeah. Yeah.
Listen back to that episode.
Yep.
I think I might need to listen back
And
to that.
then tricyclic antidepressants also have analgesic effects. So who we consider this for, IBS with visceral hypersensitivity. It's going to improve the visceral hypersensitivity, but notably tricyclic antidepressants slow GI transit.
So diarrhea patients with
Yes.
visceral hypersensitivity.
Yes. And
Yeah.
as many of us know, the American College of Gastro, or the other one,
North American Academy, yeah.
one of them, they come up with these consensus statements for how we treat IBS. One of them did say there's a strong recommendation actually that we use TCAs to treat the global symptoms of IBS. I just want to really specify IBS diarrhea.
Yeah.
But you can also use very low doses, and you can also get it in liquids. And so
Totally.
perhaps some people with IBS-C would tolerate it still.
However, we'll get to the SSRIs and why low dose of those may be better.
Okay.
Because the bowel effects are opposite.
I will say that these drugs I happen to use a lot. And I have this one patient in particular who I think this was the missing piece for him, actually.
Totally.
We tried everything. We tried the microbiome dysfunction.
Yep.
We tried the bloating. We tried like literally everything. And it wasn't until we started him on a low dose tricyclic at bedtime, which also improved his sleep, that we started to see pain. On the flip side, I also have a lot of patients who were given this class of drugs and just did not tolerate them.
Totally.
Like did not like how they were feeling.
Or their gastro didn't tell them what it was for.
Right.
So they went and picked up the drug that was supposed to fix all their problems, and they're like, oh, my gastro just thinks it's in my head. And they never took it. They never tried it.
Point.
So educate your patients on this connection.
That's a really
why we're
good
giving
point.
this.
And and it's also used for migraine prophylaxis. If they have that as well, you could use it.
The
for both
data is actually
indications.
pretty good for a lot of these drugs. You just really need to educate people that we're not dismissing them. We don't just think it's their anxiety. Like there's an actual read here. But so anyway, we want to start really low, like you said. So for example, 10 milligrams amitriptyline, 10 milligrams dizipramine, which is another one.
I've never used that one. Have you?
No.
Another TCA with a gradual dose titration upward. We are going to see the effects in the bowels before any cognitive psychotropic effects.
Oh, is that true?
Yep.
Huh, interesting.
And
if we want to keep people at a low dose, that's good.
I always learned nortriptyline works just as well as amitriptyline with less side effects from the neurologists we learned from when we were in training. So.
Yep. I see most GIs give nortriptyline now. It seems to be the best and better tolerated than amitriptyline. So the push is mainly for that one, low dose. So have you guys given it? You mentioned
for sure. Yes.
Yeah.
I've given it. I have patients coming in with it.
Yep.
I will say that I have, if they tolerate it really well.
Yep.
If they don't tolerate it, they're going to come off it pretty fast, and they're actually probably going to be resentful because they don't know why they're taking it.
Yeah.
And you can also titrate up again with the liquid. You can titrate up pretty slowly because some of the side effects will go away, and you don't have to aim for a super high dose.
Yeah. So I think about it: diarrhea, visceral hypersensitivity. Like we're not getting traction. We have a lot of other things. We could do a whole episode on visceral hypersensitivity and how we address pain here, but that's a really big part of IBS and bowel issues that people forget.
Yeah.
So it will help in a lot of folks with that, but you don't want to give it to constipated people because a main side effect of our tricyclics is constipation.
Yeah.
So not a win. Okay. What do we think about SSRIs in the gut?
Well, so people do get loose stool sometimes as a side effect. So I think that's probably what you were saying, that if you have an IBS-C patient, I just don't know the data as well for SSRIs and bowel.
Yeah. We don't really know why these help, but they do in some people. Can anyone name an SSRI?
Lexapro.
Prozac. Fluoxetine, which I think is Prozac. Sertraline, which is Zoloft.
Those are the main
paroxetine,
ones
fluoxetine, sertraline, escitalopram, and citalopram. So those are the five generally.
Lexapro, Prozac,
Paxil.
Oh, Paxil's the one I'm missing. Zoloft. That's the one I'm missing.
Yep.
Paxil's a tricky one. I feel like
don't use it as much.
Well, it's the only one that's safe actually while you're nursing and while you're pregnant. I think it doesn't cross into the placenta, but it causes atrocious weight gain. I mean, very significant weight gain. So,
I mean, pregnancy. So serotonin in the gut. What do we know about that?
It causes motility.
Totally.
Yep.
It moves things.
Yep. And it's made mainly in the gut.
Yeah. And this is like, I don't have any data on this, but I think there are some bodies that are just have struggle with serotonin.
Yep.
Maybe just like aren't making enough of it. They tend to be depressed. I see a lot of like PMDD and they're constipated.
Yep.
Maybe like there's some genetic SNPs involved.
Maybe. I don't know. I just like, this is a type of person and they fall into my office because they've got kind of the cluster of things, but they need serotonin drugs. And if we can minimize the quantity of serotonin drugs for these folks, great. But they definitely can affect the bowels. They're going to be way less constipating than our TCAs, and they definitely help with pain.
So pretty much this is like, I'm always like, okay, this is the anti-opiates or the opiates. Like they have diarrhea, we give them the opiate-like things, and they have constipation, we give them the anti-opiate-like things. That's kind of what we're doing with the antidepressants.
Yeah. I mean, I think, I don't want to bash on drugs in general. Like, thank goodness we have drugs.
Yeah, totally.
Some people's bodies just need stuff, and we can give them a quality of life if their body can't regulate on its own. Like all of our endometriosis things that we have to keep people safe, really.
Yep.
But if someone's depressed and they're constipated, think serotonin.
Yep.
If they have PMDD, think serotonin. Like, have that on your radar as something to consider. So this one increases transit, or SSRIs in general, increase transit, mild prokinetic effects. They're analgesic as well. Think about it for your folks with IBS constipation, IBS mixed, visceral hypersensitivity, and very likely associated depression or anxiety.
Yeah.
Those are the people. It is the most supported for IBS-C than all the other antidepressants. And the studies show that adding this in as part of a treatment or as the only treatment significantly reduces treatment seeking.
Is there any particular one that's recommended over the others that you saw?
I mean, you all know these, so I think it's really worth weighing the side effects, risks. What else is? I mean, we are not going to be giving SSRIs to treat IBS-C. This is going to be like, more is going on for this patient. We're looking for creative options, reducing pill load, addressing multiple things.
And they have that picture of depression.
Exactly.
That's really causing the struggle.
Yeah. So, I see them help. I probably have the most experience using Lexapro with bowel stuff. Prozac and Zoloft are next. But I think the pain piece is real. Mm-hmm. It's often overlooked. And that, when we're looking at studies for IBS and where these guidelines came out from IBS treatment, is don't underestimate the pain, because treatment seeking is the same. Like, people are really coming to doctors for the pain. A lot of us can get bowels moving.
Yeah. That's not the hardest part.
Totally. Yeah. So these ones are the same. Effects on transit precede any effects on mood. So start slow.
That is something really interesting, because I've definitely seen, when I'm starting antidepressants for patients, for the depressive, symptom,
they have the side effect.
They have the side effect within days of change in bowel habits.
Yeah. Mm-hmm. My question that I can't really find in literature is, I see a plateau effect in the bowels.
Yeah.
So transit wise, I don't necessarily see that in the pain piece. Like, it stops working on the pain or whatever. Like, people just seem to be good to go. And is it because, we're fixing the gut or the brain, whatever? But the bowel stuff tends to taper off.
Maybe it has to do with the receptors getting used to the agent. Like we talk about with other motility agents, you have to switch them up after a while.
Yeah. Yeah.
But that's so tricky to do with antidepressants.
You can't just take people on and off.
Because they're like, if you ask me, when I taper antidepressants with patients, slow but steady wins the race.
So slow. And especially that like very low dose to nothing is where I see like by far the most side effects.
And patients describe crazy side effects. Like they'll almost describe like
it's awful
static in their brain, or like they'll have a thought and then a couple of seconds will pass and then they can have their action. It's like not fluid and communicating.
It's really rough.
So, switching, playing around with these is not something you can play around with very freely.
No, but the benefit of when we're talking about gut stuff specifically is we can do the very lows. We can do liquid dosing or, quartering pills or things like that to just see, if that's sufficient, kind of like with prucalopride, start slow. So those are
the other thing I want to say is this does not have to be the only thing we're doing.
Right.
Like we can also layer it in with our naturopathic treatment protocols to see if we can get some benefit there.
Yeah. And I think, another piece of this is if we're putting people on these just for mood, what do we tell them they can expect bowel wise, transit wise, pain wise? It's not just pain in the gut.
Right.
And people who have IBS, like a very, very, very common, maybe top comorbidity, anxiety and depression.
Right.
They go together. It's like the American public. So
yep, totally.
We could talk about that all day. But anything else on SSRIs? Any other thoughts?
No, I do feel like they're pretty ubiquitously available.
Oh yeah.
It's important to know.
They're probably in our water at this point.
Something for us to think about is like, just remember every 7 years they lose their patent, right? Yeah. So they slightly change the drug. Yep. That's what's citalopram versus escitalopram.
Yeah.
They had to change their patent. So first it was Celexa, and then they had to make a little change. Lexapro, interestingly, is actually safer than Celexa because they don't have as much of the cardiovascular
you don't have
risk.
to check prolonged QT.
Yeah,
totally.
Intervals. But so just remember, this is also a game that the pharmaceutical company is playing with us. Mm-hmm. The newer ones are not necessarily better.
Yep. Yep. They all have different side effects, different profiles, but, they affect the gut. So SNRIs.
Okay, hold on. Wellbutrin?
Nope.
Effexor?
Yep.
Oh,
venlafaxine.
Venlafaxine, and then what's the new
epinephrine, norepinephrine.
Yeah. So there's selective serotonin, norepinephrine reuptake inhibitors.
What's the new one that Prestige is a new
exactly.
That's basically a Vexor.
Cymbalta.
Oh, Cymbalta.
Oh, I didn't know that was in that. Okay.
And Savella, which is one that I don't know very
I've never
well.
heard of that one either.
Yep. So these are acting on serotonin and norepinephrine.
Okay.
Would we give these for bowel stuff? No.
Oh.
Like these, they do have they do affect the bowels in a very, very specific way we'll get to here in a second. Do you know what the difference is between the different drugs?
Well, duloxetine's kind of one of the go-tos for pain and mood.
Yep.
That one's fibromyalgia. That one's actually the only drug approved for
I've had patients have a really hard time tapering off of that
these are tough drugs because they're acting on two neurotransmitters.
Yeah.
Home run for people who need them.
Yeah.
The only difference between all 4 drugs that we have in this class is the ratio of serotonin to norepinephrine.
Okay.
So some bodies just need different things. But that's, you kind of shop around for what works. But we have some data that, for certain conditions, a ratio of a certain type is better.
I will definitely say that every single person that I've had on this has a very difficult time coming off of it.
Yeah.
It is tricky with that.
Yeah, because it's messing with more. It's messing with more.
Totally.
The one thing this does is alter colonic compliance and tone.
What does that mean?
Rectal pain.
Huh. So
temporarily?
Yeah, I mean, while you're taking it.
Okay.
Yeah, so we actually do have data that this one is helpful for rectal pain. There is a study that compared venlafaxine, which inhibits both these neurotransmitters, appeared to decrease the sensitivity of the colon to distension. So for some people, that's a bad thing. Atonic colon, we do not want to give that. That's just have on your radar, not a win for those folks, and that's a lot of people.
Yeah, I have a patient who was actually started on Cymbalta.
Yep.
And she has the worst constipation ever, and she did not tolerate it. She felt like she was a zombie.
So that may be part of why.
Yeah.
Because if they're already having trouble getting that signal to the brain to poop, or they have a long history of laxatives or things like that, and the nerves are just kind of messed up, SNRIs might not be the best option for them. Mood stuff can outweigh the rest of it, but yeah. So we talked about the differing affinities for these. Venlafaxine, just so you know, has a 30-fold higher affinity for serotonin than for norepinephrine. Duloxetine is 10-fold. And then the newer one that I'm not as familiar with, the Savella, that's a 1-to-1.
Oh.
But these can increase blood pressure. They can cause nausea more than any of the others, but great for rectal pain. So, I don't know, fissures, things like that can be, they don't have studies on that kind of stuff, but it might be worth knowing.
I might have missed it. Do these cause constipation?
I am not aware of any definitive transit data on that. The other two for sure, I'm guessing, but honestly, I don't know which way it would do it. So most of my patients who have been started on these will report something, but I don't know that I can consistently say one way or the other.
Because I don't know, this is not on the top of my list.
I know.
Like the tricyclics for me is a little bit of a no-brainer. I feel like we've been using them forever.
Yep, just caution and constipation.
Yep, the SSRIs, I get that makes sense to me.
Yeah.
I guess I've had such a rough time getting patients off of these.
Yeah, for sure. And when I presented this in my overall constipation talk, I had sections on each of these pages on who you have on your radar for this. And this, I just literally have a question mark.
Yeah. For
bowel stuff, I have no idea, except maybe that rectal thing, but suppositories, get them pooping, fiber, squatty potty, we have a lot of other options, but it's a neat little factoid about it. We obviously are lacking a lot of data on this. And like you said, with the turnover of these drugs, we've got a ways to go. But I do think if you're having really pesky cases of visceral hypersensitivity, because of adhesions, because of microbiome stuff,
I mean, for me, visceral hypersensitivity is so difficult to treat.
Yep.
It is not.
Yep.
Yeah, it's tricky.
Yep.
So maybe it's more just knowing the effects of the SNRIs on bowel function.
Exactly.
looking to use one of these medications specifically, like you said, outside of rectal pain.
Yep.
It's just kind of knowing what else it might do if someone's on it.
Yeah, and knowing, there's a lot of serotonin in the gut. It's definitely, especially the different ratios of the drugs, the ones that act more strongly on serotonin, probably it's affecting transit in some way. We can kind of just use what we know about that. But I think we have a lot to learn how these affect the bowels.
Yeah.
So.
And I'm often also thinking about like the herbal interventions that we can give that kind of fit this mechanism.
Yeah.
But I'm going to say I don't know if I've seen the same efficacy from the herbal interventions that I have from the pharmaceutical.
For visceral,
like
500, or like just tryptophan, 5-hydroxytryptophan,
tyrosine.
Right. Any of those, I don't.
So when I was at DUW like 5 years ago at this point, they were working on formulating a sustained release 5-HTP because it does affect the gut. We know that.
I think there are some.
Yeah,
well,
I think there are some
too.
World,
not in the pharmaceutical world.
I don't know if it's enough.
Right. Maybe it's not enough.
Because it just
also
acts so quickly.
Like therapeutic dosing for 5-hydroxytryptophan is anywhere from like 500 milligrams to 4 grams. No, I'm lying. From 50 milligrams to 4 grams.
Right. Okay.
You know what I mean? Like there's a wide therapeutic window there.
Yeah. And like at what dose are we actually affecting serotonin in the gut? Like, I don't know.
And then my other question is always how much of that 5-HTP is being broken down.
Yeah.
Right? It stays in the gut.
I will say, back to when we were talking about getting people off their last dose of SSRIs, I use 5-HTP then.
I would agree.
To kind of just give a buffer.
SSRI.
Exactly.
Right.
Serotonin thing.
Right.
To kind of just buffer that final jump. I see help. But in the gut, I know it's in a lot of our like prokinetic formulations and things like that. I don't know. Like we don't use it alone. I think it's just kind of a throw in.
I do also think that there is a dosing issue. You know what I mean?
Yeah, maybe that's why some of the supplement versions are not potent enough for gut issues. It's hard to say. That would be nice to have some research on that.
Totally.
And I will, whenever we look from like the animal trials to the human trials, that like dosing literally drops like almost 100-fold from how we're doing it, just because it becomes cost prohibitive, right?
Totally.
And we're trying to put it into a little capsule or a chewable. And so that's why I'm like, I think it's not, I at least don't have great success using the amino acids, which is usually what I use for the mood.
Right.
Yeah.
For the GI.
Yeah. So in what cases might you, like visceral hypersensitivity in general, what cases might you bring on board like a TCA or something like that?
I mean, I think the way you broke it down was pretty spot on.
Yeah.
If they have diarrhea and visceral hypersensitivity, I'm thinking tricyclics. And I will also say it's not the first thing I try.
Yep, for sure.
But it's definitely on my list.
Are you doing peppermint?
I'll try peppermint. Yep. I'll try the carminative herbs. Yep. I'll try, treating the
visceral
underlying
manipulation.
Acupuncture.
Really helpful.
I try neurotherapy and injections.
Totally. Yeah.
So that's what I'll try first.
There's often a stress component too. Not that it's in the head, but just a normal stress component on any pain central pain,
which is why I also use like the hypnotherapy.
Yeah.
Totally.
Yeah, like I feel like I'm like bought in on that with a good hypnotherapy team.
Yeah.
Yeah. Or the Curable app I recommend to people.
Oh, that's a chronic pain one, right?
It is, but it encompasses more than just pain. So it encompasses all of the old sort of kind of some of the books we've mentioned from a long time ago. It's built on that, and some of the newer doctors that are bringing that work forward on sort of the emotional aspects of chronic pain and retraining how the brain views pain, and they call it more of a neural circuit disorder.
Cool.
So retraining the parts of the brain.
I mean, it makes perfect sense.
It makes perfect sense.
And some people, when they're going through stuff like that, do need drugs, you know, to kind of support them through it. So, not bad to consider these. I have gotten requests from some of the mentorships that I'm working with right now that when we're talking about these things for people who aren't geared in like functional medicine, naturopathic medicine, to give examples of how we explain these concepts to patients. Okay. Like what wording we might use to get some buy-in, because they're going to just like how a conventional doctor may just be like, go get your script. This is going to help.
Right.
And then they'll go get it. So what might you say if you're starting one of your patients on a TCA?
Listen, we've tried a lot of things. Yep. We haven't gotten anywhere. Like I'm honestly, because it's always going to be there.
Totally.
Because, like it or not, what every physician does is they throw spaghetti against the wall.
Yep.
And if it sticks, great. But if not, you have to find other spaghetti to throw, you know? So we might try. There's a lot of data on this particular TCA, mainly because it seems to be working on that neurocircuit between the pain, the GI, and the brain.
Yep.
And so that's what we're working on.
And it's been around for a long time. We've used it pretty regularly for many decades. We can go low with dosing. We don't have to aim for some super high dosing or anything with severe contraindications. But I like the fact that it can be titrated pretty easily.
Totally. Yeah. And it's like reversible. If
Yeah.
it's not a win, it does, we have tools to get you off of it.
And it's not that hard to get people off of those compared to some of these other medications we talked about.
Yeah. Yeah. I'll say something very similar, that like medicine, I'm interested in what's working for you.
Yeah.
And sometimes we have to shop around for the thing that works for you. And that's sort of the beauty of what we do, is our toolbox is way bigger. It takes some time to figure it out. And in all of our great theories on how we develop meds and the perfect things they're going to cure, and then we put them in humans, which are much more complicated than our science.
Yeah.
It does different things. Cholestyramine, cholesterol, but wow, it's great for diarrhea.
Yeah.
This is another example. We use it. I mean, it was generated to treat depression and mood stuff, but it totally affects the bowels. So
it's really so interesting because, half of me is always like looking for that long, big data set that really shows me how to go. And the other half of me is like, this is an individual.
Yep.
And I practice precision medicine.
Mm-hmm.
You know what I mean? Like, I'm trying to be precise for you.
Yep.
And it's not easy to overlay those two things because this huge data set might just be a want for your patient.
Totally.
And so I think you just need to have buy-in, that you have more ideas, and this is a process.
Yeah. And we get the outliers.
Yeah.
That's like what we do.
Yeah.
If conventional system worked, they wouldn't be in our
Right.
office. So.
Totally.
Works for a lot of people, but that's why we're here.
Definitely works for some people.
Yep. I definitely personally, in my constipation decades long journey, was given these drugs. And I was resentful of the GI. I was like, he's just blowing me off. He doesn't, it was like in my undergrad. Yeah. He just thinks I'm stressed. And like, yeah, I am, but I'm stressed because I can't poop. If I could poop, I'd feel a lot better. And maybe he should have recommended something else there too, or given me 2 seconds.
Or just explained
exactly
that he was treating your
Yes,
gut
there's a
well.
reason, because I was in pain.
Yeah.
I was in pain, and maybe it would have been good, but I didn't even try it.
Right.
So I was like, this is baloney.
Yeah, I mean, I do think so much of it is explaining.
Communication.
Totally.
Not easy.
Communication. It's not, and I also have empathy for the gastros. You know what I mean?
Absolutely.
Like 5 gajillion patients in one day.
They don't have the time, but that's where we come in.
Yeah.
I always tell them they have the fancy tools, they have the fancy brain. We need them.
Yeah.
I will be your friend.
Yeah.
I'm going to help translate this for you and explain why maybe they recommended this, because people need that if we're ever going to get folks better.
Yeah, for sure.
So this is a big example of that.
Right.
Okay, I think I do have a better understanding of when to use these drugs. This was great, Dr. Sam.
Yeah. Awesome.
Should we do a quick recap?
Yeah.
So we talked about tricyclics and using them particularly for IBS with diarrhea and hypersensitivity. If there's no pain component, we don't really use these for gut issues. SSRIs, we're not going to them only for gut issues, but if they also have other comorbidities, those can also have an effect, particularly with IBS-C. And the SNRIs, more just kind of like an FYI. If someone's on this for other reasons, these are the things it might do with the gut.
And maybe it helps rectal pain.
Yeah.
Maybe it helps. Yeah. I am using more caution in people who have like raging diarrhea, putting them on an SSRI.
Yeah.
Because that's like our go-to first line for a lot of people.
That
but
makes sense.
That has informed how I do this.
That makes sense.
So thanks for tuning in,
All
Turd
right.
Nerds.
Thanks, guys. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.